Good day. Good day. My name is JP Leong, and I'm here to talk to you today about the challenges of working with osteoporotic fractures. So we're going to discuss what is osteoporosis, what are some of the problems with managing osteoporotic fractures, some tips and tricks on how to deal with osteoporotic fractures in your practice, the role of secondary fracture prevention, and the role of new drugs like denosumab in treating secondary fractures from osteoporosis. Osteoporosis is defined as a systemic skeletal disease characterized by low bone mass, microarchitectural deterioration of bone tissue, and an increased bone fragility and susceptibility to fractures. Studies have shown that osteoporosis can cause more than 8.9 million fractures annually, resulting in a fracture every 3 seconds. In the postmenopausal women, a decrease in the level of estrogen leads to an increase in the rank ligand, and this leads to an excessive amount of bone resorption due to the overwhelming of the osteoprogenitor cells by the rank ligand, which is expressed. This leads to an imbalance between the resorption and formation of the bone, which leads to osteoporosis. These changes can be seen in both cortical and cancellous bone. In cortical bone, this can be seen as a decreased thickness, which is although the absolute bone diameter of the bone increases as one ages, the cross-section of the wall itself continues to narrow. Cross-sectional images of the cortical bone show not only an absolute thinning of the wall, but also an increased weakness and increased hole or lacunae formation within these bones, which leads to an increased weakness predisposition to low energy fractures. In cancellous bone, there are less and thinner trabeculae with fewer and often broken interconnections. This can be seen in the picture in a young normal lumbar spine on the left-hand side compared to that of an osteoporotic lumbar spine on the right. This bone loss accelerates after menopause in both cortical and cancellous bones, leading to the changes that you see in osteoporosis. And these changes lead to an increase in the risk of fragility fractures as one increases with age, such that there is a 7-fold risk in the incidence of a second fracture after a patient sustains a hip fracture or a prior clinical vertebral fracture. It has been estimated that about 86% increased risk of another fracture among women who have sustained a prior fragility fracture. The projection is expected to show that by 2050, there will be an estimated 3,250 million fractures in Asia alone. And the Philippines will have its share of this increased number of fractures. So what are the difficulties of working with patients with osteoporotic fracture? These difficulties are twofold. The first is that of poor patient stock, and the second is that of poor bone stock. Briefly, patients who are elderly and who have osteoporotic fractures usually have an advanced mean age of around 80 years. By this age, they will have a number of comorbidities, which naturally increase the risk of surgery for these patients. These patients will also have secondary problems because of the fracture itself, like metabolic problems, problems with management consent, scheduling, discharge planning, as well as polypharmacy, which can further complicate the issue. For this lecture, though, we're going to discuss more of the problems which occur in the bone itself. As previously mentioned, osteoporosis can lead to a decreased thickness of the bone, and this leads to a decreased working length of the implant, which is almost like doing osteosynthesis on an eggshell. Global demineralization affecting both cortical and metaphyseal bone happens in osteoporosis, seen in this picture of an elderly patient with a distal femoral fracture. And you can see the increased outer and inner diameter of the cortex, weak, thin cortices, metaphyseal flaring, and the loss of trabeculae. Fracture patterns usually include extensive metaphyseal comminution with complex, small, and short articular segments as well. The changes in cancellous bone seen also lead to a reduced and cutout resistance to implants and the formation of bone voids as bone is crushed during the fracture itself. So signs of poor bone quality in patients include patients with multiple vertebral compression fractures, patients with previous hip, distal radial, or tibial plateau fractures, patients with end-stage renal disease, and patients on steroid or anticonvulsant therapy. It will be highly likely that if you have a patient with any or more than one of these, that you will be dealing with bone such as this in the pictures below. The consequences of this are you will have patients with more fractures, operative complications will be more common, failure of fixation, secondary loss of reductions, iatrogenic fractures, and even spontaneous peri-implant fractures. So what are some of the special considerations in fixation of fragility fractures? The IOF has made a list of suggestions on how we can deal with fractures in osteoporotic bone. These include the use of implants specifically designed for osteoporotic bone, considering void filling as a strategy in the management of osteoporotic fractures, using intramedullary instead of onlay devices, and considering the use of arthroplasty or hemiarthroplasty versus osteosynthesis in hip fractures where applicable. Implants designed for osteoporotic bone include the use of fixed angle locking plates and bone sparing methods like using blades rather than screws which drill out holes in the bone. The use of locking head screws has also improved the fixation of the pull-out strength due to both the increase in the root diameter as well as the stability brought about by the locking of the screw to the locking plate itself. Other clinical advantages in osteoporosis of the locking head screw is that the locking head screw cannot be over-tightened and used to compress bone underneath. It has a high resistance against bending forces, and there is no secondary screw loosening because the screw remains locked to the plate. This is likewise suitable for minimally invasive procedures to try to maintain the vascularity of the fracture site. Void filling can be done with either cement or bone graft or resorbable material, which can be used to both maintain the reduction of a fracture after it has been compressed or reduced. Augmentation has taken a step further with the use of implants which are compatible to this technique, including the use of fenestrated holes within your implants, after which application of the implant, you can then inject cement through the hole in the implant and improve the purchase of the end of the implant to the native bone. This has been done in both trauma as well as spine, where you have fenestrated pedicle screws which can increase the bone implant interface by augmentation around the inserted screws. Whenever possible, in dealing with fractures which are unstable in configuration, you can use an intramedullary device, which is a more stable construct rather than an onlay fracture device. So the recent trend towards the use of proximal femoral nails and intramedullary nails can help prevent displacement in these injuries. The last strategy is the use of arthroplasty as an alternative to fixation. So knowing that bone healing is very difficult and prolonged in patients with osteoporosis, using an early arthroplasty technique like either hemi or total hip arthroplasty can allow earlier mobilization for these patients. In a meta-analysis of 14 studies with over 1,900 patients, the group of Bandari has showed a 5-fold higher revision rate with ORIF compared to hip replacement. although the hip replacement group did have a higher dislocation rate. Their initial studies also showed a relatively higher infection rate, increased blood loss, and slightly increased operative time in the hip arthroplasty group, but there were no difference on post-op pain and function compared to either group themselves. There was a trend towards increased mortality, but did not reach significance. So let's talk about specific techniques you can use in your practice on how to deal with osteoporotic bone. In this particular case, patient underwent bridge plating for a comminuted fracture of the distal tibia. And if you note in this particular technique, the surgeon used a divergent screw pattern proximally. So using a divergent screw pattern allows you to capture more bone and increase the stability or the capture of the implant against the host bone by being able to capture it in different planes. The second case shows a 75-year-old woman with a humeral shaft fracture in which the patient was tried to be treated with an absolute stability technique with the use of an interfragmentary screw. However, this interfragmentary screw, as shown in the area of the yellow arrow, led to a comminution of the fracture at that area due to the weak, brittle nature of the osteoporotic bone. So this was then remedied by putting in a bridge plate instead, and this eventually led to healing of the case. Another 70-year-old female with a distal femoral fracture over a total knee replacement. So for patients like this, one tactic that can be done for osteoporotic patients is to use long spanning plates with relative stability instead of absolute stability constructs, and being able to bridge long and capture the fracture in the middle, and this can lead to healing with callus formation for the fracture. So these are the applied fixation principles in osteoporotic bone. The use of relative instead of absolute stability constructs, lock splinting with long plates or nails, divergent screws to maximize bone fixation, load distribution with no specific peak stresses, don't use interfragmentary compression in weak bone, and aiming to get secondary bone healing with callus formation. Remember not to mix your principles and methods for these cases. There are continuing problems with osteoporotic bones, however. So the group of Ko and al. Showed the incidence of early adjacent vertebral fractures after balloon kyphoplasty for osteoporotic vertebral compression fractures. So even if you're able to put in a balloon kyphoplasty in osteoporotic bone or osteoporotic spine fractures, you can get subsequent adjacent level fractures as well. Another case shared showed a 40-year-old female with chronic renal disease and a bone mineral density score of -7. This patient sustained a proximal femoral fracture, and because of the weakness of the bone, the decision was made to use arthroplasty as a treatment technique rather than ORIF. However, despite the arthroplasty, the bone was described to be paper thin and subsequently led to intraoperative fractures in the management of these patients. So this led the surgeons to have difficulty in fixing this bone, even with an arthroplasty technique. So this just highlights the point that you need to address the underlying osteoporosis for these cases. So the management includes both acute management of the fracture, but this cannot be separated from the chronic management of the underlying osteoporosis. So remember, optimal care of the fragility fracture patient doesn't just involve diagnosis and fracture management acutely, but also rehabilitation and secondary prevention as part of the treatment itself. In a study done from different hip centers in Asia, it has shown that 2/3 of patients with a fragility fracture are not investigated or treated for osteoporosis. Only 50% were actually informed that they had osteoporosis, and only about a third underwent BMD measurement or received treatment for osteoporosis within 6 months after discharge. The results of this study were actually mirrored in a similar study done locally, where a study of awareness and treatment rates following fragility fractures of the hip in Filipino patients showed that among 180 patients with osteoporotic hip fractures, only 20% actually received osteoporosis treatment. So this shows the big gap we face in secondary fracture management. So we go back now to what are the options for us in treating osteoporotic fractures. Remember, a healthy skeleton requires a balance of bone resorption and bone formation. When you have decreased estrogen levels, this leads to an increase in the rank ligand expression, and this increased rank ligand can overwhelm the OPG formation in the bone. This then will lead to activation of your osteoclast precursors, differentiating your osteoclasts, and this increased osteoclast activity can lead to an increase in bone resorption. Bisphosphonates mainly work by binding to the bone and inhibiting the osteoclasts at the bone surface. They integrate into the bone and they enter and inhibit mature osteoclasts, preventing the resorption of bone in this area. While effective, the concern about bisphosphonates, particularly with prolonged use, is the possibility of atypical fractures due to a thick but brittle bone which does not remodel. In contrast, denosumab, which is the first-in-class rank ligand inhibitor, inhibits osteoclast formation in the first place by binding to and inhibiting the rank ligand. This prevents the rank ligand from binding to the rank and eventually inhibits osteoclast formation function and survival, thus preventing excess bone resorption. The difference with this is that denosumab is reversible. It has no permanent effects to the bone itself, such that when you discontinue the use, you can actually resume the native physiology of the bone. So some of the studies in support or showing the effectiveness of denosumab include the FREEDOM study, which is a double-blind study comparing denosumab to placebo, involving almost 8,000 cases over a 3-year period of time. This study showed almost 70% relative risk reduction in new vertebral fractures, a 40% relative risk reduction in hip fractures, and 20% relative risk reduction in non-vertebral fractures versus placebo. In head-to-head studies against other bisphosphonates, including alendronate, risedronate, ibandronate, and zoledronic acid, Prolia also showed similar, if not superior, effects in bone mineral density improvement. So the FREEDOM study was then extended up to 10 years, and it showed that there was a low incidence of fractures maintained over the course of 10 years with Prolia, and that the sustained increases in bone mineral density over 10 years were measured at key sites in the body with a relatively low incidence of atypical fractures, even at this prolonged period of time. So for primary fracture prevention, treatment is initiated after bone mineral density is used to confirm osteoporosis. But with secondary fracture prevention, after a patient sustains a fragility fracture, there is no need to do a BMD, and immediate treatment for osteoporosis can be started. This slide is just to highlight that denosumab is effective against all forms, including vertebral, non-vertebral, and hip fractures, with the convenient dosing of a subcutaneous injection given twice yearly. So please don't underestimate the role of orthopedic surgeons, as shown by this study, which shows that fragility fracture preventive treatment compliance is better if initiated by the surgeon themselves. So what are the key messages of this lecture? Age and osteoporosis affect cortical and trabecular bone in different ways. The surface contact area between the implant and the bone is the most important for implant anchorage. In diaphyseal fractures, relative stability reduces stress concentration, and fracture splinting can be done with long locking plates. For metaphyseal fractures, locking plates can be used, impaction of the bone to have good bone contact, and consider the use of blades or higher surface or contact area implants to allow better purchase in your weak cancellous bone. There is a need to address the underlying osteoporosis for all of these fractures, and orthopedic surgeons are in the best position to start and ensure continuing osteoporosis treatment. So denosumab, a rank ligand inhibitor, is effective in reducing hip, vertebral, and non-vertebral fractures. So with that, thank you very much for listening and have a great day.